All right, great. It looks like there's quite a few people here. Thank you so much for joining us tonight, and hello. My name is Paige. I'm with Gemelli Biotech, the makers of the Trio Smart and IBS Smart at-home gut tests. We are so thrilled to have you with us tonight, and we hope that this conversation provides you with valuable insights and helps debunk some popular misunderstandings out there. I'm so excited to introduce Dr. Mark Pimentel, an internationally recognized leader in the field of gastroenterology and microbiome research. Dr. Pimentel is the executive director of the Medically Associated Science and Technology Program, or what is called MAST, at Cedars-Sinai, and one of the foremost experts in IBS and SIBO, IMO, and ISO. His tireless research has revolutionized how we diagnose and treat these complex conditions. Dr. Pimentel will begin tonight with a short presentation covering some key insights about these conditions, and then we will bust some common myths. And after that, we will answer, or he will answer, some of the pre-submitted questions and then some of the live questions that come in on the chat for our Q&A. While we receive hundreds of questions, and thank you so much for sending them, they're really great questions, and we wish that we could get to them all. Unfortunately, time is limited, but when we move into the live Q&A portion, we encourage you to submit your questions in the chat box. That'll come to me, and I will be able to ask him in the time for the live segment. Unfortunately, Dr. Pimentel cannot comment on specific medical cases, but we will try to get to as many questions as possible. So without further ado, Dr. Pimentel, the floor is yours.
Thanks, Paige. I really appreciate it. And thank you for spending your pre-holiday evening with me. For some of you who are on the East Coast and abroad, I'm really excited to be here, actually. I have a question for myself, which I'll start with later, but I'll save it for then because it's a question I got this morning, which I thought was the first time I ever got that question in my whole career. So I thought it was interesting. But I'm going to talk, I'll get to that, and I'm just trying to keep you a teaser question. But let's talk about small intestinal bacterial overgrowth. I think what I'm trying to do tonight, like that's different than other times. I think those of you who've heard me speak before, you're like, okay, the same slides again, Dr. Pimentel, and maybe it's going to be the same old thing and boring. And I always put new slides in. I always give a refresh of information because there's always new information, even a month later. But I want to just pause and say, like, you have to understand that SIBO is an epiphenomenon. It means that if your gut is moving slowly for whatever reason, now IBS is the most common cause, and so we focus a lot on IBS because if you were to take the entire SIBO in the world, IBS is the biggest chunk. So we spend a lot of time there, and also because patients tend to be more dismissed or doctors are less educated on the relationship between IBS and SIBO, and we spend a lot of time there because it's the biggest chunk. But any of these things can cause SIBO. Morphine for 2 weeks can cause SIBO in a normal person. So anything that slows the gut down can cause SIBO. So I always want you to be mindful of this. We have now data on hypothyroidism. We have new data on some autoimmune diseases that can cause SIBO or be associated with SIBO long term. So this list is growing as we start to understand all the different things that can slow the gut down. But our main focus will be irritable bowel syndrome, as it usually is. And if you've seen this slide before, I was my entire career, starting in 1996 here at Cedars-Sinai in Los Angeles, has been about root cause. I'm not a believer in you have pain, take morphine. If you have pain, what is the cause of the pain? Treat that. If you have diarrhea, an anti-diarrheal or Imodium is not the treatment. The treatment is, what is the cause of the diarrhea? Treat that. Because I don't believe that constipation is a treatment for diarrhea, and I don't believe that diarrhea is a treatment for constipation. So the laxative approach for constipation, of course, there are patients we don't quite understand why they have constipation, and you have to resort to these things to give people some relief. But I'm always a believer of spending a lot of time trying to figure out, why do you have this? Get rid of it, because I want people to have a normal bowel movement, a normal life, a normal evening dinner with family out. And that's been my goal all along. So the root cause, that's key. That's the key thing. And I believe, based on the data, we have enough evidence to say that 60% of IBS is a microbial overgrowth of some kind, whether it's SIBO and ESO for diarrhea or IMO, methanogens for constipation. But finally, and I say this with great pleasure, finally, and you probably haven't seen this slide, people are understanding this notion. We should stop thinking of IBS as a diarrhea condition and a constipation condition. We need to look at the biomarkers, breath testing, the IBS SMART test, bile acid testing. We need to convert IBS into a biomarker-based treatment. If you have this, you get this. If you have SIBO, you should get antibiotics. If you have, so this is all the new lay of the land. This is paper after paper after paper. Literally, this year, a third paper, a huge paper, is coming out just in the next few weeks, saying the same thing in one of our major journals. Enough is enough. No more criteria. Let's do biomarker treatment. Biomarker treatment. And that's what we've been doing. That's what you and I and those of you who have joined my podcast or these conversations over the last years, that's what we've been doing. And now it's happening. So that's very exciting. But the cause of IBS, the root, is food poisoning. Food poisoning. Ever since then, I have IBS. You don't even have to remember it. It could have been one day of diarrhea 5 years ago, and you've had diarrhea ever since. So you don't know that it was food poisoning in the beginning. But the pooled prevalence is 1 in 14%. So out of 100 people at a wedding who get food poisoning, 14 will end up with IBS if the whole wedding got food poisoning. So this is real. This is a real cause. And we now know what that cause is. It's this CDTB toxin, cytolethal distending toxin. It's common to all the pathogens, all the organisms, Shigella, Salmonella, Campylobacter, E. coli, that cause food poisoning. And we can measure this. So this is basically the IBS SMART test. I do this in all my patients with diarrhea because A, it stops the idea that IBS is a syndrome. If this is positive, IBS is not a syndrome, it's a disease. Because you have a biomarker, you have a molecular marker that says you had food poisoning, now you have irritable bowel syndrome. And, there was, I'm going to share a tiny story which really irritated me. I was at a fundraiser because somebody dragged me to a fundraiser for Crohn's disease and ulcerative colitis. Love that. Help patients, happy to help fundraise. And they were on stage and they were, trying to get the audience excited about Crohn's and ulcerative colitis. And they said, what's important, why you need to donate to Crohn's and ulcerative colitis is because it's not IBS. And what they were trying to say is IBS is just a nothing. Crohn's and ulcerative colitis is a real disease. I can tell you, I see IBS patients. It's not a nothing, and I didn't donate much. So I'll give you that. I was so upset that they would be dismissive. I am not dismissive of ulcerative colitis and Crohn's disease. I am not. It's a big disease. It's a big problem. But don't diss on IBS because that's miserable. And especially, not to mention the fact that it's miserable as hell and everybody thinks it's in your head because they can't find anything. So this biomarker, this blood test says, stop it. It's not in your head. It's a real disease, and let's get on with this. So that was a interesting moment for me in the last month and a half. So the second thing is this test is really a marker. Medical certainty is 80%. This breaches medical certainty, and if both markers are positive, it's 98% certain you have IBS. And the sensitivity is exactly around 60% because 60% of IBS we believe comes from food poisoning. That's what I feel is happening. So this is really a great test, and I use it in everybody with IBS D in my practice. But when you give this toxin to animals, they get overgrowth. That's what causes overgrowth. And they get two types of overgrowth. One is E. coli overgrowth in some of the animals, and some of the other animals, they get desulfovibrio overgrowth. So there's two types, and both are causing diarrhea. But this is hydrogen-producing gas, and this is hydrogen sulfide-producing gas. So if you get food poisoning, you might go in one of two directions as a human. And we now know that humans do go in those one of two directions, just like these rat studies. But when we do breath testing, it's now absolutely clear that breath testing is more abnormal in IBS than healthy. This is not 25 studies. This is 25 studies pooled together, all independent outbreaks independent breath test studies that show that breath testing is positive more in IBS than healthy. So this is like thousands of patients, and so it's really important to understand that. So we've done breath testing, we've done culture. This is the sequencing data, and the reason I keep highlighting this is because we were the first to shotgun sequence the small intestine in SIBO. Who is SIBO? And we now know it's just two bugs. It's Klebsiella and E. coli, and Klebsiella pneumoniae specifically. They account for almost half of everything in your small bowel when you have SIBO. And these guys, as I've said in many lectures, are the Ferraris of the gut in terms of fermentation. They ferment so fast and so hard and so efficiently that they basically say, everybody out of my way, go away. We're going to win this battle for food because we're getting all the fresh stuff that you're eating. And so they're the Ferraris. And look at this, 63 times faster at fermenting sugar because you have SIBO than the guy next to you or person next to you on an airplane. But now everybody's on board. This is now in the last couple of years, everybody's on board. We started the North American consensus in 2018. We said, hey, IBS and SIBO are real. Hey, this is how we should do breath testing. And now in 2024, everybody's on board across the globe and saying, yeah, we see it too. We see it too. It's real. And so this has now really been beneficial to patients globally. But we had to get a third gas because the third gas, sulfur at the bottom, intestinal sulfide overproduction, is the key to understanding the true nature of the diarrhea in patients with diarrhea. So you have to measure all three. Because if you look at IBS diarrhea, they don't have methane. That's the blue line here. These are IBS-D patients. There's no methane. It's only the constipators that have methane. Methane's associated with constipation. But the hydrogen is associated with diarrhea. That's the blue graph here. And the majority of IBS-D patients are over 20, so they have SIBO. And they have hydrogen sulfide in the D group. But we've gone so far as to validate this three-gas breath test more than any other breath test in history. And what I mean by that, because we have these new technologies, so we're doing a breath test in the morning on these patients on this slide, and 20 minutes after we do the breath test, we're scoping these patients, we're getting juice, and we're sequencing the microbes in their small intestine. And sure enough, the breath methane correlates with the methanogens or methane-producing organisms in the small intestine. So methane's coming from the small intestine. And we know methane slows the gut down. That's we've known since 2006. So methane really is the problem. We did the same with hydrogen sulfide. That's a new gas. We know more about hydrogen sulfide than we did even about hydrogen, and we had hydrogen on breath tests for 30 years up until a decade ago. So in the last 10 years, we've caught up so much in terms of understanding hydrogen sulfide, and methane, that all three gases are practically caught up together. And these are the organisms that produce hydrogen sulfide in the small bowel, and it correlates with your breath. So the breath is actually telling you how much you have of these bad characters. This, I'll announce today, is in press as of this morning, this big study. I'm only showing a snippet of it. It is a very large study with a lot of graphs, and I'll be able to share that once it's publicly available. But this was presented at the DDW, so this part is public information. But essentially, 6,000 people across the country were eligible to participate, and 3,200 did the breath test, did the questionnaire, the Trio Smart questionnaire, making this again the largest prospective study of breath testing. And basically it shows if you have hydrogen sulfide, the higher it is, the more diarrhea you have and the more urgency you have. So the breath test works at home. It works at home. You can mail it in and it works perfectly. And methane correlates with constipation, all the things we've known. And so these symptoms go along with the breath test. But what it boiled down to is we now know who's who, who's ESO, who's SIBO, and who's IMO. And it allows us to develop treatments. We know rifaximin works for IBS, but it works because you have overgrowth. So if you are a positive breath test, you're more likely to respond to rifaximin than if you had a negative breath test as an IBS patient. So the breath test actually tells you you're going to respond or not. So that's really important, and that's why we do breath testing in our patients. So if you have overgrowth, rifaximin, you're more likely to respond. Again, this is hydrogen overgrowth, and that's what this meta-analysis shows. But if you have methane, you need two antibiotics. You need neomycin plus rifaximin. That's how you get the best benefit. This is a study now almost more than a decade old, but basically it says if you take rifaximin and neomycin, that's the most likely to drive that methane down for today. And I'll show you a couple of things that will tease you into tomorrow or the future. What we don't know how to do yet is to treat hydrogen sulfide, but we know some. And the sum here is that Pepto-Bismol, or bismuth, as you see on this slide, can kill these organisms. So when we combine that with rifaximin, we get a good response for hydrogen sulfide producers. But we have a new drug that we're starting the trial. Finally, January 2nd, I'm announcing it here today. The drug is being labeled right now in a warehouse in Ohio. And we're hoping to get the trial kicked off January 2nd. We're already collecting names on our list for people with IBS for this trial. And then finally, elemental diet. This is the Mbiota, the palatable elemental diet. This is now published, so I need to change the slide. It's no longer DDW. It's actually published in CGH. And basically, you can see what happens to the breath test after elemental. This is hydrogen now down to normal because by 90 minutes, it's less than 20 here. And then methane over 10 is abnormal. And now after elemental, it's down below. So elemental diet's hard. It's expensive because you have to pay for it, but you save money. You don't eat for 2 weeks. But it is quite effective at dropping these gas levels. This to me is one of the most impactful things that reflects the work that we have done for 25 years, because for the first time, an IBS document now has the luxury of all these newer studies. Now, this is still 2022, 2023, not all the really new cool stuff, but cool enough new stuff to say IBS and SIBO go together. That's statement 5. Constipation and methane go together, statement 6. And food poisoning causes IBS, statement 7. That's the first time it's been declared in a consensus guideline in the world. So IBS is changing. I'm going to finish before we go to questions because I really wanted a lot of time for questions this time because I know people really like that. And this is CSO6. This is our drug that we discovered that actually fits in the socket of the methanogen M-smithii enzyme that makes methane. And on the right, this was presented this year. If you are a constipated rat with methane, and we are able to create this model, if you take this drug, you're not constipated and the methane goes down. So in vitro work, meaning in the lab, we can get methane to go down by 80 to 90%, depending upon the experiment with this drug. So this is the next thing. We need about a year and a half before we start human trials in this, we hope, if all goes well. And finally, this is rifaximin 2.0, you could say, but we call it Rifaximax. If you combine rifaximin with NAC, you dissolve the mucus where some of these E. coli and Klebsiella and Proteus live, because rifaximin can't penetrate that very well, and you get rid of the rest of them. And so we now know that we can make IBS much better with this combination, and we did one human trial already, and it was gangbusters. And this is the trial we're doing starting January 2nd with these rifaximin and NAC in a special delivery system. So this is the way I treat, or I use the breath tests. First of all, if you're diarrhea, I do IBS Smart in all diarrhea patients because it legitimizes you. This is not Crohn's disease, folks. This is IBS. This is not ulcerative colitis. This is not celiac. This is IBS. IBS is a real disease because your IBS Smart test tells you it is. Number 2, we do the breath test, and the breath test will tell me which treatment to use. So if it's sulfur, I give the rifaximin and Pepto-Bismol. If it's overgrowth, I give rifaximin. And if it's methanogen, I give rifaximin and neomycin. And I sometimes use the elemental diet if those don't work. But we got new things coming on the right-hand side, so very excited about that. So I'm proud to say this work has resulted in IBS being a disease, no longer a syndrome. Food poisoning is the root, and IBS Smart can tell you that. Trio Smart is now the most validated breath test in history, and that third gas really gives you additional information. You need to measure all three. And new therapies are coming because we understand this condition more than we ever have. So I did a short presentation today because I wanted to spend a lot of time talking about your questions and trying to answer them. And I know I need to do that because the questions that I'm getting from you guys are way too smart because you guys have listened a lot over the period of time. And some of these questions are really, really good, and I need to get to them. I got a question. This is what I want to get. I got a question this morning. I was doing a seminar for practitioners all over the country, and they wanted to know about SIBO and how to treat it for their patients. And somebody says, do you ever get burned out seeing these patients? And I thought about that question, and I said, well, yeah, I do. I mean, these are difficult cases. We don't see easy cases. But then I thought about it some more, and I said, yeah, I do get burned out, but if I didn't get burned out, that means I didn't care because these are tough cases. So yeah, we put a lot of effort and energy into trying to figure out the patients in our clinic. And yeah, it's tough, and yeah, it does affect us. So yeah, that's okay. It's okay to be burned out if you care about patients. So I don't mind answering the question that way. But I'm going to get to your questions now. But that was an interesting question. Nobody ever asked me that. Can you please clarify if the condition of interstitial cystitis is related to SIBO? And this is from Aaron, it says. So Aaron, if you're out there, so interstitial cystitis is tricky because let me go back because I don't show this in the slides today. When you get food poisoning and you get those antibodies, we think those antibodies are causing the nerves, the pacemaker cells of the gut to sort of disconnect. These are called the interstitial cells of Cajal. They are the pacemaker cells of the gut. The exact same pacemaker cells are in the bladder. That's why often when you have cleaning waves, that's the time you also want to pee. We see this when we do the manometry test, and then the cleaning wave comes, and we missed it because the patient was in the bathroom peeing, because it turns out that when you get the cleaning wave, it also activates your bladder because it's the same nerves. So we do see interstitial cystitis in SIBO. We just don't know how to manage it the way we would manage IBS. So I hope that answers your question. Second question we got is there a holistic way to treat SIBO without medications? And if so, does the SIBO go dormant or cured? So this is Natalie. Thanks, Natalie, if you're there. So there are many ways to try to mitigate the effects of SIBO. SIBO is not life-threatening, but we have an abstract we're presenting at DDW, we hope. We submitted it like last week, so I can't tell you the details of it, but we were shocked because we were able to see how you, as a human, how your lining of the gut and the contents of the gut are feeling about SIBO, and you're not happy. Like your gut is not happy SIBO is there, and it is fighting the SIBO. So you have to imagine that the gut is very distressed about all these bacteria being there and their toxins and other things. And so you've got to be feeling fatigue and depletion of energy or depletion of or feeling sort of like a mild flu because patients describe this. So yes, medications can make that much better. You can do it holistically, but you will probably reduce the symptoms by 20%, 30%. This would be with diet, maybe sometimes herbs and other natural remedies, but you're not generally going to get the response you get from like antibiotics. So let's see. Can IMO be the sole cause of functional vitamin B12 deficiency? If so, once the overgrowth is treated, can functional B12 deficiency with associated symptomatology be resolved and no longer B12 requirements? So one of the ways you diagnose SIBO in dogs is you measure a folate level, and you can measure B12 also. But basically, when you have really, really, really bad overgrowth, it can eat up your B12 and you can have less B12. But overgrowth produces folate, so your folate can be high. So people with a high folate, we suspect SIBO too. So it can go, there's two things that can happen. But generally, if you get rid of the overgrowth, B12 supplementation may not be needed. But remember, B12 can be caused by a number of things, including autoimmune gastritis. So you have to check with your doctor to be sure you know what type of B12 deficiency you have. Um, so could you please speak on possible mechanisms of brain fogs with methanogens? This is Amelia. So this is very fascinating and a little bit tricky to explain, but if you ever heard of the old anesthetic, carbon tetrachloride. Carbon tetrachloride is a carbon molecule with four chloride molecules connected to it. Methane is a carbon with four hydrogen molecules connected to it. So chloroform is carbon tetrachloride, essentially. So that's what used to be used as anesthesia. We now use isoflurane and fluorane, which are hydrocarbons, like methane is a hydrocarbon. So methane, in fact, is a sleepy gas. It makes you tired, but it's not as potent as carbon tetrachloride or N-fluorane or isoflurane, the anesthetic gases we use in the anesthesia suites now. But you can imagine it makes you feel fatigued or sleepy and tired. And so that's the brain fog that you might experience with methane. And we do see that very frequently. We ask about it in our patients. So you are right, methane can cause brain fog, and that may be the explanation. Low fermentation diet with strictly no eating between meals. That seems to be, oh, let's see what it says. Fermentation diet with strictly no eating between meals. And that seems to be helping much more. Why is IMO so much more difficult to manage than SIBO? So there's two things from Carol here. So our low fermentation diet is really sort of two aspects: what you eat and how you eat. What you eat is basically foods that don't ferment as much, but not as restrictive as low FODMAP. And then how to eat is to space your meals, because those cleaning waves that you have, you only get them when you're not eating. So if you're not eating, you're getting cleaning waves. And so if you're eating all the time, you're never getting cleaning waves, even as a normal person. So it's essential that you have times between meals of fasting. So that's what we do. But EMO is more difficult because EMO these are not bacteria. We didn't devise antibiotics for methanogens, which is why we're getting creative, combining antibiotics and all that. But we're hoping the CS06 drug will be the cure for EMO or the remedy for EMO. We're very excited about that. So stay tuned for that. What are the implications for chronic diarrhea post gallbladder removal? The person is just given their name as D. I don't know who D is, but D is the person. But post gallbladder removal can cause bile acid diarrhea. That was also on my cause tree that I had in the beginning. We don't talk about that here today, but we do look for bile acid diarrhea in patients who've had their gallbladder removed. The next question was prokinetic plus repeating the breath test and possible retreatment with antibiotics. Is there a reason to follow any other low fermentation diet? This one's a little confusing, but we do prokinetics after treating for overgrowth in patients who relapse. So if you have a patient or you're a patient or somebody with overgrowth, and then you get treated and you respond very, very well, but then a month or two later it comes back, you treat again, you're doing great, we might consider a prokinetic at night to make those cleaning waves go, because you're not having enough of them on your own. And frequently we can prolong the remission for up to 6 months, 9 months, even a year if you stay on the prokinetic. I'm going to read the question before I read it out loud because some of the questions got a little scrambly. Is it possible to heal EMO? I kind of answered that question. Oh, why does Dr. Pimentel prefer barium studies over CT scans to find the underlying cause? This is Luke. Luke, I'm not old school. I am new school. I like CT, I like MRI, but I can tell you for a fact that old school barium radiology trumps CT enterography for adhesions any day. Why? I'll tell you why. So, because when you do a CT enterography, is you drink a lot of stuff. It's not like a regular CT where you drink a little. CT enterography, you drink more of this material that shows up on X-ray. And then they wait for it to get into the small bowel. And then they lie you down and throw you in the machine. And they do, within 1 minute, they do the entire scan. And they look for areas where the gut is a little bit dilated and maybe there's a kink there. And if there's a really, really bad kink, they can see it. Okay. But when you're looking for adhesions, the adhesion could be up against the front wall of the abdomen, up against the back wall of the abdomen, up against the top of the abdomen, the sides of the abdomen. When you do a barium test, they actually lie you on your left side, your right side, upright, backwards, forwards, because they can see where the adhesion is coming from and how it pulls on the bowel. In a CT, you're lying down. That's it. You get what you get, and you don't get upset. So you cannot see where the adhesions are, and you cannot see the pulling of the adhesion if it's not coming from the front of the abdominal cavity. So you're going to miss adhesions with just a plain old CT scan. Barium's the only way to find it. I hope that answers your question. I'm happy to get more specific about that. I'm just checking the time. How do GLP medications affect gut health, especially related to SIBO? GLP-1s cause SIBO. We didn't know that for sure a year ago, but we now know that based on numerous publications at DDW or presentations at DDW, that if you're on a GLP-1, you're going to have SIBO. You may be less symptomatic with your SIBO because the food never gets to the SIBO, but anything that slows the gut down, and now we add GLP-1s to that, can cause SIBO. Is methane often seen in mixed IBS or IBS-M? Who is this? This is Luke again. Thank you, Luke. Yes. So mostly in men, because men tend to be less prone to constipation than women. In a study we did on women versus men and the spectrum of IBS, when a female patient has methane, they get really bad constipation. When a man gets methane, they tend to be a little bit more mixed bowel habit. So yes, methane can be there. Okay, let's go to the next question. Let me see who's doing this one. Gwen, let's see. IMO patient, 2-year ordeal, now in remission after 2 rounds of Xifaxan and neomycin. I'm glad to hear that. Last treatment was 4 months ago, now on prucalopride and working well. Okay, great. But what do you recommend for the long term? As I understand, this can lose efficacy, and I'm concerned about IMO returning. So let me tell you how I handle my patients. I can't give you medical advice for your own situation because everybody's different. But we see this all the time in clinic. You get the rifaximin and neomycin. Finally, you get the methane gone. You're on prucalopride at night or in the daytime. Sometimes depends on the patient and the situation. And everything's going well. And so we generally keep the prucalopride going in my patients for 6 months to a year, depending upon how tough it was to get rid of it. Because I don't want to stop the prucalopride and say, hey, we've gone up 6 months. All right, 6 months is the limit. Stop. And then the patient relapses. And then we spend another 6 months trying to get it gone again. So it's really kind of a negotiation on how miserable the patient was before. And if they're doing really great, we continue the prucalopride a year and a half. We'll do whatever it takes, depending upon how bad they were before the prucalopride started. But I'm glad you're doing well, so that's very exciting. Should I continue taking Motegrity while treating? This is actually interesting. It's back to back, but this is Sandra, a different person. So should I continue taking Motegrity while I'm treating SIBO? So for my patients, when I'm treating the SIBO, I really don't care about the Motegrity. And I basically say to them, Motegrity, as sort of suggested in the last question, You can, in some patients, get used to it over time, and then it works less and less, and you have to increase the dose. So if you're on Xifaxan or rifaximin for the SIBO in the next 2 weeks, just give your body a break from the motegrity, because when you start taking it again, it'll work better because you've given your body a break from it. So I stop it. What form of bismuth do you use when treating hydrogen sulfide? And the answer, this is from Rajri. And so, Rajri, so I use Pepto-Bismol, honestly, and I use a capful 3 times a day. That's what I do. And they take it right with the rifaximin, same timing. Um, so, on another question here is from Carol, and Carol says, how accurate is the TrioSmart SIBO breath test? Because mine showed all 3 gases are within the normal range. So would the IBS Smart test be the next step to help determine the cause? Do SIBO or IBS contribute to a mesenteric hernia? So that's a very confusing aspect of this question, because the question is there a mesenteric hernia involved? Because a mesenteric hernia can cause all sorts of symptoms, and the TrioSmart could be normal. So the way I use these tests is, if they are normal, you got to look for other things. Those are the patients I scope and do other things more aggressively. But ironically, doing these 2 tests up front actually saves about $800 per patient, because if you have a positive TrioSmart and IBS Smart, I'm on the right track. I'm treating you the right way. If you respond, this is what it is. It can't be Crohn's disease. It can't be ulcerative colitis if you respond to rifaximin. It can't. So I don't need to get a colonoscopy in the 25-year-old person who responds to rifaximin. And you save money, time, and the patient's copay, and a whole bunch of stuff. So that's how we use the test. But if it's negative, you need to think about other things. That's basically how I practice with this. Can SIBO IMO actually be cured to the point where you can eat normally without fear? If yes, how long does it take? This is Lori. This is a tough one, because as long as those antibodies are elevated, if you have those antibodies, this will be a recurring problem that has to be managed, and we're better at managing it, as you've seen today. But we are working on a treatment to get rid of the vinculin antibody. We published a paper in the summer, I didn't put it in my deck, that in the patients where we can get rid of the antibody, you don't eat anything. You can eat anything. Everything's back to normal, potentially. So we're working on that. That is a much longer time to develop. It's not going to be in 1 year, 2 years, 3 years. It's probably a 5 to 7 year plan to get to that point. I don't want to be discouraging, but we are working on it, and we know how to do it. It just is a more complicated thing to do. So stay tuned for that, though, and hopefully we'll be there. I'm going to do one more question, and then I'm going to pass it over to Paige for a few minutes, and then I'm going to come back to the questions because there's a lot going on. If TrioSmart lactose breath test is negative, but if you still have bloating and constipation, what do you suggest? I think I already answered that question. So Paige, why don't I kick it over to you now, and then I'll come back to more questions and then do the online chat questions at that point.
You got it. Thank you so much. Can you see my screen? Is it all working well?
Yes, we see it. Thank you.
Okay, wonderful. Thank you for answering those questions. That's amazing. We had a lot of myth busting in there of some common misconceptions of how to treat, how to manage, how to diagnose. So that's very helpful. Some of the testing that he was mentioning about IBS, post-infectious IBS, and breath testing for SIBO, IMO, and ISO. We provide some at-home testing kits that you can get online from Gemelli Biotech that will diagnose and address what Dr. Pimentel is speaking about. So Just one moment. There we go. So these are the two tests that we focus on at Gemelli. TrioSmart is the only three-gas breath test that is available that measures hydrogen sulfide. So you can get a diagnosis of SIBO, IMO, and or ISO. IBS Smart is an at-home gut test as well. It is a capillary blood test, and it attaches a little tasso device to your arm for a capillary draw. Pretty much painless. It takes a very small amount of blood, and you mail it back, and you can get the measurements of your antivinculin and anti-CDTB, which are the biomarkers for post-infectious IBS. TrioSmart, again, is the only at-home three-gas breath test. It is the only three-gas breath test available anyway. It is the only one that does hydrogen for SIBO, methane for IMO, and hydrogen sulfide for ISO, and it gives you all of the information on your phone or on your results that show all the graphical information on the time frame of each of your bags for the test over time frame of having a sugar consumption. Right now, we are trusted by over 100,000 patients for TrioSmart specifically. We are the most sensitive test by having 20 times more sensitivity than a traditional two-gas breath test. We are the #1 CLIA certified at-home mail-out breath test. And we also have a service where you don't need a doctor's appointment or you don't need to see your GI to get the test. You can order it online and use an intake form for our doctor, and we can write the test for you if you're approved for that. And you can bring the results in to your GI in the next appointment, and you can go through what the best plan of treatment and management looks like for you. So it's very helpful to just bring in your results right to your doctor to make a game plan. Also, we do have glucose and we do have lactulose available now in the direct-to-patient telehealth portal. So you can select either glucose for your substrate or lactulose for your substrate. And you can just select different questions on the intake form to select what's right for you. IBS Smart, again, is the only at-home test for post-infectious IBS. It attaches right to your arm, and it's virtually painless. A little amount of blood goes a long way, and you can get a report for in the same way of showing you the exact values of your antibodies if they're elevated or not elevated. Post-infectious, again, is IBS that's caused from food poisoning. It's predominantly a diarrheal condition. So people that have mixed or diarrheal predominant IBS would want to look into IBS Smart because the facts are that almost 11% of people with food poisoning in this country will develop IBS or post-infectious IBS because of food poisoning. So definitely good to get yourself checked out. But we do have a sale going on right now for you specifically from this webinar. If you wanted to go onto our website, get gut answers, and I'll put everything in the chat so you can just click and save as you need. But if you use code MYTH50, this will take $50 off any of your Gemelli tests. So if you do a bundle with TrioSmart and IBS, it'll take $50 off each of those products as well. So plug that in for the online ordering only. Unfortunately, this code is not valid with your private doctors. We also run our giveaway for all of the registrants that come on and watch these live Q&As every couple of months. This is the Microbiome Connection book written by Dr. Mark Pimentel and Ali Rezai. And this has so much incredible information. I can't even begin to explain what's in it. It's everything you need. And you can enter to win this book just by going to this QR code or this bit.ly code. I will put the bit.ly code in the chat as well, but we're giving a copy of this book away for 2 people, and we'll announce that winner in the recap email that goes out after the webinar is complete. But again, I will put that link in there if you don't have your camera out right now. Again, thank you so much for joining us tonight. Also, thank you very much, Dr. Pimentel, for taking some extra time and answering some additional questions here. There's so many to go through, and they're really, really good questions. Again, if you wanted to go to Get Gut Answers, that has everything from IBS Smart, Trio Smart. We also have some malabsorption testing on there as well. And don't forget to use the code MYTH50 to get $50 off your products. But I will hand this over to you again, Dr. Pimentel, and I will put the coupon and all of the information links in the chat for everyone to see as well. Okay. Dr. Pimentel, you are on mute, just so you know.
Now that you brought up the myth 50, I think there are myths that we need to go through that were covered in my lecture, but I think these are very important for you to understand as you sort of assess this lecture. IBS and SIBO only affect women and are related to stress and anxiety. It's all in your head. I hope I convinced you that's not true. It's not in your head. And to be honest with you, it's almost equal men and women. And so while, women tend to get more constipated, men tend to get more of the diarrhea, but in general, it's almost equal, although there are slightly more women with IBS and SIBO than men. There are no long-term effects of food poisoning. I think I've convinced you that food poisoning I'm not trying to make you paranoid about food poisoning, but I kind of am. And our doctors that I speak to all across the country, I gave grand rounds out East Coast, Cleveland Clinic. People are more afraid of food poisoning than they used to be because they know this can cause IBS. IBS and SIBO, are they the same? The answer is yeah. I mean, they're the same, but IBS can cause, SIBO can be causing IBS, but SIBO can also happen with a lot of other conditions. So don't forget that. And I think that's what I showed you in the beginning. IBS can be treated once and then it's gone for good. I wish it was like that. It is for some patients. Some patients, it's treat once and they're fine indefinitely. So I'm very happy that that happens sometimes, but it's not always routine. SIBO, IMO, ESO, and IBS are caused by pathogens. They're not really pathogens. They're just taking advantage of the opportunity that they were given. So when the gut slows down, they're just ready to take over. And as soon as the gut starts to function normally again, they behave. And so I think that speaks to this antibody. If I can get that out of the blood of patients, this could be cured potentially. So more work needs to be done. But it's not pathogens. These are just the regular guys in your gut that are taking over because of the impairment that you have from food poisoning, for example. And you don't need a breath test to guide treatment. I don't know how you do it without breath testing because there's 3 types. So each one is treated differently, whether it's SIBO, ESO, or IMO. So you got to know which type. I'm in the dark if I don't do a breath test. And that you got to use 2-gas. I'm not here to bash 2-gas breath testing. I've done it for a long time. But what I know is hydrogen sulfide is really important. And the paper that got accepted today is going to tell you exactly how important hydrogen sulfide is when you get that information in January. But we already know it's associated with diarrhea and gives you one further angle to treatment that could help some people. And diet alone can cure IBS. Hard to do. It helps, though. It helps. But elemental diet might be able to get you an improvement in SIBO as good as antibiotics. But you have to do 2 weeks of liquid diet for that. And gut cleanses, detox teas, enemas. You can clean your gut out. You can reset the gut by cleansing it out, but it will just come back. And it doesn't we see patients, for example, who get a colonoscopy and they say, oh my gosh, my IBS for 1 week was better. And I'm like, yeah, we see that all the time, but 1 week is not a benefit. It's just because you washed everything out. So be careful with that. There is no clinical test for post-infection IBS. I showed you IBS Smart. That's the one. And stool testing cannot diagnose SIBO. I'm sorry. There's people out there who purport that. It's not diagnosing SIBO because the small bowel is so different than the colon. So I'm just going to go and stop the myths and go back to questions if you don't mind. And I have a lot. So this is from Betsy. Please provide percentages of full recovery of SIBO following rifaximin. Also, kindly tell us about the serious dangers of using neomycin. I've been struggling with SIBO, methane dominant, which has now changed to a mixture of constipation and diarrhea. being on a low FODMAP diet for 8 weeks did nothing for me. I've been on antimicrobials, celery juice. Um, please address the use of enzymes, hydrochloric acid. Um, is it possible streptococcus virus caused SIBO? Okay, so there's a lot here. I'm going to try and address as much of it as I can, but I need to get to other questions as well. But here's the thing, Betsy. So if you give rifaximin and you had a positive breath test, the chance of you responding is 56% just by taking it properly, 75% if you're able to make that breath test normal. So it's important if you don't respond or don't feel like it worked to get a second breath test, because if the second breath test is normal, you need to look for other things too. Because let's say you had an adhesion and I gave rifaximin to a patient who had an adhesion. I can make the breath test normal with rifaximin, but they're still having symptoms from the adhesion. So if they still have symptoms, but the breath test is normal, I got rid of the overgrowth from the adhesion, but I didn't get rid of the adhesion. And I got to go and do that barium study. So you can see the logic of what I'm doing when I'm treating patients. So if things aren't working the way they look like they should be from our slides today, you need to think about other things or what other else things could be going on with that person. And maybe that applies to your case, but I mean, I can't give medical advice, as I said. All right, I've got something from Kelly. Is IMO also from food poisoning? Kaiser isn't on board with breath testing. Kaiser is getting on board with breath testing. I can't tell you much more information from that, but Kaiser has to date done 300 breath tests as they're finally piloting it in their system. And if all goes well, fingers crossed, talk to your doctor. It will start to be done in Kaiser. But, they have to do their assessment. They have to make sure it's cost effective. They have to, Kaiser is a very careful system. They don't want to just do something because everybody's doing it. But stay tuned. Maybe Kaiser rolls in. But talk to your doctor about that because I think it's going to come. But IMO is not from food poisoning. We don't know why people get methanogens. We think it's from their family because you grow up in that environment, sharing food, toilets, that sort of thing, and you get exposed to that organism. It colonizes, and then for some reason, it just becomes too much in your gut, and then you get that. So let's go to the next one. Wendy Edwards. Will it be possible to have access to the slides? Paige, I believe you're going to be sending the presentation at least to those who've attended. Am I correct?
Yes, there will be a replay within 24 to 48 hours that will be sent out to their emails.
Okay. So Rita Corona, how reliable are TrioSmart test results? For the first time in history, we can say that when you have a hydrogen sulfide that's here, you have hydrogen sulfide producing bacteria in your gut that's here. It's accurate. It's telling you how many of these organisms are in your gut. When is TrioSmart going to be covered by insurance companies? So TrioSmart is covered to some extent by many insurance companies. But the challenge is insurance companies don't pay the full price often. And so it's a bit tricky. Same thing happens in every institution. We do breath testing here at Cedars, and we have the same sort of problem. Even though this has been around for a long time, insurance companies make their own decisions, how they make their decisions, and it's really hard. They don't pay for rifaximin often. I don't know. I don't know how to fix that problem. But it's a real problem, and I'm sorry that that's the case. But we try to do our best for our patients as best we can to get these tests and these medications. But there's all sorts of reasons behind the scenes that we don't always understand. So I apologize for that. Lawrence, if a 75-year-old man with breath test positive hydrogen SIBO responded a year ago to rifaximin, but symptoms recurred 8 months later, which is pretty good, and again a positive breath test, but he didn't respond the second time. TrioSmart breath test again positive for hydrogen, allergic to penicillin. What would your next drug be? So this is a really interesting question because we did a study where we looked at patients who were treated up to 6 times. And it was a very bizarre study because if rifaximin worked the first time, it almost always worked again and again. But there were patients where It worked the first time, did not work the second time, but worked brilliantly the third time. And I went back and asked these patients, and I said, like, did you take it differently? Were you a little more liberal with the way you took it because, you figured it's just going to work? And I couldn't quite figure it out. But if they can afford it or if their insurance covers rifaximin, you might want to try a third time. And I'm not trying to push rifaximin. I know the days before rifaximin and how neomycin by itself, you get resistant. Ciprofloxacin by itself, you get resistant. People were getting resistant to all these antibiotics, and you don't to rifaximin, generally speaking. So you might want a third try. I'm sorry to push it back that way, but Lawrence, if that's what I would do in my clinic, is recommend to the patient a third try because I've seen that where one time it just doesn't work for reasons we don't understand. Patrick, is it possible that toxic mold exposure may play a role in SIBO IBS? And if so, you and your team looking at environmental factors as a root cause. It's really tricky with mold, right? Because a lot of people are exposed to mold and we don't know how it's affecting. Um, I don't know exactly. We're not working in this area specifically. What I can tell you, which is super interesting, is that in our Reimagine study, we're doing sequencing of shotgun sequencing, which sequences everything, including mold in the gut. We don't see a lot of toxic mold, but we do see penicillium in some patients. And in those patients, they have less bacteria because the penicillium is producing penicillin in their gut. And we wonder whether maybe some people have penicillin in their gut naturally, and that's controlling SIBO. I don't know the answer, but it's very fascinating and deserves more attention. I agree with you. Um, Aram, if methane keeps relapsing within a week multiple times with antibiotics, even while taking motegrity and pancreas is normal and no adhesions, what can be the reason? So if there's one gas that tends to be stubborn, it's methane. We have patients where very hard to get rid of methane. These are the patients that I truly encourage to try the elemental diet because we do see some of these patients really respond to elemental diet. So I do elemental diet in this situation routinely for my patients. Joe Tarkov, any recommendations for treatment-resistant IMO after fundoplication surgery? So I don't know how many of you know what fundoplication surgery is, but if you have heartburn, really, really bad reflux disease, taking the top of the stomach and wrapping it around the esophagus creates a little bit of pressure that makes reflux less. The problem with that is you have no chimney anymore. And what do I mean by a chimney? A chimney to release gas. So people with IMO or SIBO, when you can't burp, the gases are even more trapped and you can get a lot more bloating and distension. I'm not saying that, Joe, you're experiencing that or that I'm just raising that as things tend to get worse. But the good thing about the fundoplication is that you can stop the acid medication because acid helps to prevent SIBO in some patients. The other problem is if you stop acid medication, you have more acid, and acid can feed into methane production. So if you get a fundoplication and you stop your acid medication, IMO can go higher if you have it. So there's a bunch of things that can happen, and I hope I didn't totally confuse you, Joe, but I hope that's sort of answers your question. I'm going to Lenore here. Lenore has two questions. Don't the antibodies wreck the microbiome? Medicare and Medicare should pay for it. So antibiotics wreck the microbiome. In general, that's true. But in rifaximin, I took that slide out. In rifaximin preferentially reduces the Ferraris and the rest of the microbiome comes back. This was shown in a massive study done by Cork, Ireland, where they looked at all the microbiome studies in rifaximin-treated patients before and after. And that's exactly what happens with rifaximin. It gets rid of the bad actors and the good actors are able to grow. Sort of like rifaximin pulled the weeds out of the garden and your tomatoes are growing better than ever. And that's what we see with rifaximin. So I can refer you to that study through Jameli if you want, or you can reach out to them and they can get it for you. Randa has 5 questions, so I'm going to try to do at least one. If TrioSmart is negative, what test do you recommend to be done if symptoms continued? What about fecal transplant? Is IBS related to eczema? So celiac is related to eczema. So if somebody has a negative TrioSmart and they have eczema, I would be looking for celiac disease in that patient in my clinic. So it's not necessarily a false negative test, which is the next question. So that's what I would do for a patient like that, Rhonda. I'm going to do 2 more questions. Hopefully, it's one of yours. I've got Romy Azevedo. Will the recorded webinar be shared to the group? Yes. So I'm going to move on. That was a Richard Guzzardi. Preferred colonoscopy bowel prep for SIBO patients, specifically diarrhea patients. I don't have a preferred bowel prep. Any one of them that your physician or practitioner uses. The most important thing is that you're cleaned out so they get a good look and you don't have to do it twice. I think that's the really most important thing. So since that was an easy one, I'm going to go to Dennis, and this will be my last question. For a patient who got post-infection IBS from food poisoning due to contaminated water, this was in 2021, what can be the explanation for the TrioSmart breath test showing high methane, but not any other gases, even though said patient was diagnosed with IBSD? Said patient also had elevated anti-CTTP and antivinculin markers. So you cannot have methane go up without more hydrogen. So there are patients, and this is now getting into black belt territory, where food poisoning triggered everything for them, and they got SIBO, and the SIBO hydrogen is driving the methane that they had by nature up. And they didn't have methane by nature up. And if it's a man, then methane doesn't necessarily mean constipation. It can be a mixed pattern where there's diarrhea mixed with or alternating pattern. So all of that can happen, especially if antivinculin markers are elevated. Whoever has the antivinculin markers, if it's you or a patient, that usually means that food poisoning did this. And so I think that's how it happened. Okay, well, it's 5:03. I think I've exhausted you with my talking. I hope this was helpful to all of you. Yes, treating IBS is difficult. It does require a lot of effort, but I'm very happy I have the chance to do this. And I love my patients. They're terrific. So thank you for your time and attention, and I hope this was helpful to you.